Welcome to Nitte, a place where learning goes way beyond the classroom. For some, it's home. For some, it's a step towards transformation. For some, it's the beginning of a wonderful journey with like-minded people.
Thanks to the teaching and mentoring activities and Dynamic Incubation Center, I am now industry ready.
Engineering at Nitte includes aeronautical, civil, computer science, electrical and electronics, electronics and communication, information science, mechanical, biotechnology, MTech, MCA and PhD. Nitte also collaborates with reputed universities around the world to give students an international academic exposure.
At Nitte, the focus on research has not only helped me understand my subjects, but reach for the stars.
Nitte offers a unique co-op program, an exposure to architects, artisans, and urban designers.
I aspire to be the heart of progress.
Chema is listed in the World Directory of Medical Schools.
I learned the art of helping people smile.
A.B. Shetty Dental College is listed as one of the top dental colleges in the country. Justice K.S. Hegde Charitable Hospital, part of the Nitte Group, has 1,000 beds, advanced labs and diagnostic centers, which attract a good number of patients from across South India. Along with teaching and clinical practices, we offer programs in pharmacy, nursing, physiotherapy, speech and hearing, biomedical sciences, and paramedical programs like respiratory therapy technology, operation theatre technology, medical imaging technology, and medical laboratory technology.
I've always been curious about the chemistry of cures. I help in healing. From toddlers to seniors, I care for them all.
I believe I can help improve the quality of other people's lives.
We are blessed with the ability to speak and hear from birth. Not everyone is as lucky. I want to do my bit to help the less fortunate. I am proud to be able to assist a surgeon in the operation theatre.
From simple X-rays to sophisticated MRI and PET scans,
my course trains me to assist radiologists and physicians. The training I have received in testing blood, tissues, and body fluids assures me a job at any clinical laboratory. I help people enjoy every breath.
I believe in the power of research to change the world.
NUINS is a one-of-its-kind teaching and research center that addresses society's health needs through painstaking research in biomedical sciences, food safety, microbiology, and biotechnology.
What I learn here and at my internship in the University of Minnesota, USA, I will carry with me and teach my community to live healthy and stay happy. We believe in being our own bosses.
The Bloomberg Lab helps students stay up to date with the latest trends in global markets. Students also have access to Bloomberg Analytics and can, in the course of their learning, develop their own analytics.
I cook my own recipe for success.
Sarosh Institute of Hotel Administration molds each student to become perfect hospitality professionals. A healthy blend of polish and panache.
I speak for the voiceless. This is what I'm taught, and this is what I'll practice.
I design my dreams and my goals.
I measure success by the trends I inspire.
Bachelors in Fashion Technology at Nitte offer students state-of-the-art labs and the space to get their creative juices flowing. With the best of infrastructure, an active placement cell, and a lively atmosphere, education at Nitte helps students grow, breathe, and bloom. Graduate into a better future. Graduate with Nitte.
Very good morning to all. I, Suchitra, take this opportunity to welcome all of you this NUINS Alumni International Webinar Series, Experientia. I take this opportunity to welcome today's resource person and proud alumni, Swati D'Souza. She will be speaking on the topic Hemodynamic Monitoring. Swati has completed BSc Nursing in the year 2010 and also completed in the year 2013 initial registration for Overseas Nurses Program, Australian Centre for Further Education, Melbourne. In the year 2019, she completed postgraduate diploma in critical care nursing. She is managing 2 units in learning and teaching health professionals in critical care program. Completed quality improvement project on urinary tract infection reduction project and ward round tool in PICU. She has got experience in various hospitals. She worked as a full-time staff nurse at Ruby Hall Clinic, Pune, in the ward medical surgical nursing and also a cardiovascular thoracic surgical intensive care unit. She also worked as a operation theatre nurse at Mangala Kidney Foundation and Mangala Hospital, Mangalore. Since December 2014 till today, she was working as a critical care nurse, pediatric intensive care unit, Children's Hospital at Westmead. Behalf of Alumni Association and College of Nursing, I welcome you, Swati.
Thank you.
It's my immense pleasure to welcome Dr. Professor Fatima De Silva, Principal, Nitte Institute of Nursing Sciences and ex officio President, Alumni Association NUINS to this webinar. Welcome you, ma'am. I also welcome all the faculty members of Nitte Institute of Nursing Sciences and organizers for this webinar. A special welcome to all the delegates who are the part of this webinar. Welcome you all. Now, I request Ms. Swati D'Souza kindly take over the session.
Thank you, Suchitra ma'am. Good evening from my side. Good morning to you all. I'm going to present on the topic called hemodynamic monitoring. Let me try to present my screen. Just a second.
Suchitra, can you share the slides on behalf of her?
Swati,
I think it's presenting. The only thing is I can do it. Just a second. Give me 1 minute. There will be always some or the other technical glitches. Just a second. Can you see it now?
Yes.
yes.
Cool. The COVID has made us do these presentations from
You can
home
see your
as
desktop.
well.
I think you need
That's
to.
great.
Yeah.
Okay, let me start with. Hopefully, everyone can see my screen and saying hemodynamic monitoring. Yeah?
No.
No.
Just you open. We can. Yeah. No, it cannot be seen, Swati.
Oh,
Suchitra, if you could do it from your end.
Yes, ma'am.
Yeah, we can see now.
Swati, you start presenting in case next you tell so that we will change.
Swati,
yeah.
please.
Could you do the slideshow? That'll be great. If you hit on the slideshow so that I can see it.
It's done, Swati.
For some reason, I can't see. Can everybody see now?
Yes, Swati.
Yeah?
Yes.
Okay,
Yes.
cool. Let's start. Sorry. So hemodynamic monitoring. What is hemodynamics? So the word hemodynamics actually says the dynamic movement of the blood in the cardiovascular system. So what is monitoring of this hemodynamics? So it's performed to attain a higher understanding of the pathophysiology that is actually included, which the disease condition that the patient has, which cannot be actually detected or diagnosed from just clinical assessment. Then you do the hemodynamic dynamic monitoring. So as I told you, the physical examination alone cannot notify your cardiac output or your preload status or how much of fluid boluses that you need or any kind of medications that have to be given, which cannot be detected only by clinical assessment. That's when this hemodynamic monitoring comes in handy. So why do we need it? As I already told you, to establish early diagnosis. So if in case there is inadequate tissue perfusion or oxygenation, and also if there is insufficient cardiovascular reserve, and also to understand the diagnosis, what the patient already has. And second one is to determine appropriate therapy. So from this hemodynamic monitoring, you can actually, as I have already said, that if in case the patient needs more fluids or the medications or any kind of other invasive procedures, this hemodynamic monitoring makes it a bit easier. And also for us to know that what's the response from these therapy that we have provided. So it indicates the effectiveness of the therapeutic treatment that we've given. So if you've given volume, so it hasn't caused a positive or a negative effect, or if you've given any vasoactive drugs like probably adrenaline or noradrenaline kind of medications, so it hasn't given us the positive response or a negative response. So hemodynamic monitoring comes in handy. So coming to the different types of hemodynamic monitoring, so it can go from basic or to the advanced. So it can be non-invasive, which we all are aware of, and to the non-invasive hemodynamic monitoring. So it can be arterial pressure monitoring or CVP pressure monitoring. So I'll come to that in my next slides. And also it can be continuous or it can be intermittent, and also it can be static to any dynamic monitoring. When I continue with my next slides, you will understand better. So coming down to basic hemodynamic monitoring. So to identify and treatment of all these cardiopulmonary insufficiency, it also includes focus history. A proper history has to be obtained, a physical examination, and also the assessment of these hemodynamic variables like the heart rate, ECG, the mean arterial pressure from the non-invasive blood pressure, which is usually there on the patients when you go into the hospital and attach them to the monitor. You can see all these numbers on the monitor. You can also see the respiratory rate, the temperature. You can also do the pulse oximetry or the oxygen saturation. You can also get the carbon monoxide monitors and, if available, urine output, and also echo, that is electrocardiography. So these are the basic ones. When you go into invasive, a bit of advanced teaching, it is invasive monitoring. So you have arterial blood pressure, central venous pressure monitoring, pulmonary artery pressure monitoring, and mixed venous oxygenation. Through all these, you come down to one particular thing, that is cardiac output, which is very essential in a patient to know what's the cardiac output, because that maintains your cardiopulmonary reserve, right? So to monitor this hemodynamics of this patient, there are 4 components involved. As you all can see here, this is a patient and there's an invasive catheter, and it is through the high pressure tubing here. And then you get a transducer through which it detects the physiological activity. So whatever pressure the patient or the arteries are pushing out through the tubings is actually detected by this transducer, and there's a flush system. So the flush system is from here. You can see a normal saline bag hung here with a pressure bag. So the flush is provided through these tubings into through the transducer, so that it helps to maintain the patency, and then it is amplified, or the electrical signals are passed through and it is actually displayed on the monitor. So these four components are actually important when you are monitoring a patient, especially invasively. So next one. So this is how a monitor will look like if you're working in an intensive care unit. So there will be a heart rate, which is ECG, and a heart rate, which is non-invasive because you're just connecting the leads on the patient. And then you have the pulse oximetry, that is a saturation number here, or you can see the graph, which is also non-invasive because it's just like a probe attached to the finger, right? And the next one, what you can see is an arterial blood pressure. Usually we like to keep the arterial blood pressure in red because red blood, it kind of gives the same symbolization. So that's why we like to put it in red, and it is named as ABP up here, if you can see, arterial blood pressure. And another one, which I'll talk about in detail later, is pulmonary artery pressure, which is an invasive monitoring. And here there is Untitled, that is, we call it Untitled, it's called the carbon dioxide monitoring, the expired carbon dioxide monitoring system, which is when if the patient is mechanically ventilated, you get this trace. And so this is how it looks like in a normal ICU setup, if you have been to an ICU before. And the next slide, we'll just briefly go around about with cardiac output. I'm sure everybody knows what's cardiac output. So it's the amount of blood pumped by the heart per minute. So how do you calculate cardiac output? So the cardiac output is stroke volume. SV is a stroke volume, and heart rate. So depending on your stroke volume and your heart rate, you can determine your cardiac output. So because I work in the pediatric sector, and I've been working there for like 6-7 years now. So for us, heart rate is really very important because that's how the kids or the pediatric population maintain their cardiac output. So if they're really bradycardic, it's really bad because obviously their heart isn't pumping enough and your stroke volume is less to give out good cardiac output. So based on your cardiac output, your cardiac index is determined. So you should know the body surface area of a person and your cardiac output, and then it gives you a cardiac index. So to determine a cardiac output, you can't just see a patient and understand, okay, his cardiac output is low, or like in the sense a numerical number I'm talking about. But yes, if you see a patient, if you see a person, if he's mottled or he's pale or he is cold to touch, you will understand that there's something wrong with this patient, right? Because he's not pink in color, or it's not naturally looking like, you know, saying, what I'm trying to say is, if he's sweaty or clammy, you do understand there's something wrong with this patient, but it's not normal. But what I'm trying to say here is your cardiac index can be only determined once you know your cardiac output number and your BSA. BSA can be obtained just by your height and your weight. And there's a formula to that. I'm not going to it. But this is it's kind of a approximate number to 2.5 to 3.5 mils per kilo per minute. So the value of this would be mils per kilo per minute. So to maintain the blood pressure, you need to have a good cardiac output and a good systemic vascular resistance. We'll come to the systemic vascular resistance, which actually gives good oxygen delivery to the tissue. So what ultimately you need to have good tissue perfusion to maintain for the vital organs to function, right? So our hemodynamic monitoring is solely based on good cardiac output to maintain good cardiac output. Right. So how is it all related? This is a nice diagram that we kind of use here at my settings as well, just to give a brief and an easy lookout on cardiac output. So cardiac output is related with heart rate and stroke volume, as you can see. The heart rate is usually set by SA node, that is the sino-atrial node. That is kind of an independent entity. So another one you can see is stroke volume. Stroke volume is determined by three factors. So you can see preload, afterload, and contractility. So what are these? As you can see my angry heart here, but next picture, it's enlarged and you can see a nice little heart which is a bit angry, but at the same time he's trying to say that if you give me a bit of filling, I can actually give you a nice output. So preload means filling. At the end, the volume of the blood in the ventricles at the end of the diastole. It makes a bit difficult to understand, but if I simplify this, is mostly the filling pressure, or if the heart is properly filled during the preload, you get a good cardiac output. It just summarizes down to that. So the volume of the blood just remaining at the diastole. So diastole is mostly the relaxation. So at the relaxation, whatever blood is remaining in the ventricles determines your preload. So what are the factors can increase the preload is like hypovolemia. If you give a lot of fluid into the patient, your preload increases. And if there is regurgitation of cardiac valves, so as everyone knows, like the anatomy, there is valve over here. So there are atrioventricular valves, and there are also aortic valves, and there's pulmonary valves and the aortic valves. So any kind of valvular dysfunction, if there is problems in the valves, there can be increased preload. That is because the heart, the blood from here, from the right atrium, is not being pushed into the right ventricle. It's just going back. There's like backflow of the blood. And in case of heart failure, with the other secondary issues which causes heart to fail or to pump properly, that can cause increase in the preload. So it's mostly the filling pressure. The next one we're talking about is afterload. Afterload is the resistance left ventricle must overcome to circulate the blood. So in case if the aorta, so how does the blood pump out from the body? It's from the aorta, right? So if the aorta has a lot of pressure, it is difficult for the blood to pump out the blood into the system. So that also can increase due to hypertension or vasoconstriction. As I mentioned, if the vessels are very constricted or very stenotic, it's very difficult for the blood to push in. So you just think of a hose pipe, or when you apply pressure at the beginning of the hose pipe, like at the opening, the amount of the pressure with what the water comes out of the hose pipe determines kind of its. You can depict it as a afterload, or you can say there's a resistance to the flow. So that also can increase your cardiac workload. So when coming to the systemic vascular resistance, so what is systemic vascular resistance, or SVR? Because when you enter ICU, this is what they're going to talk, like these are the jargon studies they're going to use, SVR, PVR. So what is SVR? So SVR is a measure of resistance of the vascular bed to the flow. As you can see here, this picture here actually tells you if there is resistance to the flow. So the blood flows obviously from RA to RV from right ventricular to the left atrium, and then it pumps into the left ventricle and goes out to the system through the aorta. And this is where this is what determines your blood pressure. And the systemic vascular resistance is if your arteries, like in the peripheral arteries, are really very stenotic or constricted, that determines your vascular resistance. So how resistant they are and how dilated they are determines your vascular resistance. So it'll increase when you give vasoconstrictors. So like drugs like adrenaline or noradrenaline kind of increases your SVR. So if they are very, very dry, like hypovolemic, the arteries kind of try to squeeze in as much as they can to just provide that increased cardiac output. And in septic shock, that is very late septic shock, because in the early septic shock, what happens is your SVR decreases because of your arteries kind of are dilated. And vasodilators. So vasodilators actually dilate, as it says, vasodilation is dilating of the vessels. So these kind of decrease the SVR, and also hypercarbia and morphine. Next, coming into pulmonary vascular resistance, which will come in place when we talk about pulmonary artery pressures. But we'll just have a small glance on what is pulmonary vascular resistance. So it's a measure, it's quite similar to what we talked about systemic vascular resistance, but it's this is in the pulmonary vessels. So measure of the resistance of the pulmonary vascular bed to the blood flow. If you see this picture here, this is mostly the fireman. So it's a fireman engine kind of a depiction. So there's a canal, and from the canal the water flows into the pump, and then it goes into the windkissel, and the windkissel is pushed out, right, to probably burn down the building on fire. Sorry, not to burn down, to reduce the flame, so the reduce or put off the fire. So what the water goes out to the spout here determines your PVR, or your pulmonary vascular resistance. But that's what it says about PVR. And the third component that I have not written here, but is contractility. It is more to do with your squeeze of your heart. So how effective are your ventricles to squeeze out or to actually contract to determine the cardiac output. So that talks about the contractility, and it is quite very independent of preload or afterload. It's more of muscle contractility, and some of the drugs really help in contractility, which are commonly used in my settings in my ICU, are milrinone, which kind of helps in the contractility of the muscles. The heart muscles. Okay, coming to the next slide. Sorry. So now let's talk in detail about some of the invasive hemodynamic monitoring, which you, if in case one day when you all start working in the intensive care unit, these are the common things that you will see. So invasive arterial pressure. So what is arterial pressure? Arterial pressure is a pressure exerted by the circulating blood on the arteries. And this is kind of determined by arterial pressure monitoring. So what are the indications? Why would you want a patient to be, or a person to be on invasive arterial pressure monitoring? So just to continuously monitor their mean arterial pressure. Not only the mean arterial pressure, is also the systolic and diastolic. Because if the patient has cardiac dysfunction, especially these invasive monitoring is for all the really sick patients, if they have come in with trauma or any kind of bleeding or cardiac surgeries or any kind of surgical patients, they are put on invasive arterial pressure monitoring. So for them, we need to have continuous monitoring. Yeah. So it also helps us to do frequent blood sampling. So instead of pricking them every now and then, especially when I'm working in the pediatrics. So in the pediatrics, we don't want to prick the kids every now and then, because at once they're going to allow you, but the second or third time they lose that trust in you. So you can't really do the the blood sampling on the kids because it's really very difficult. But yes, instead of pricking them again and again, it's good to have an arterial line, and it also is useful for blood sampling. The next third one is your true heart rate in the presence of dysarrhythmias. So when we work in the ICU, it kind of if the patient is like moving around, or in the sense in the bed, like twisting and turning, it's difficult to really note their heart rate. Sometimes what happens is it suddenly appears zero. It doesn't mean that patient has died or has suffered asystole, but it means that probably the patient is turning or the leads have been disconnected. So at that point, the arterial pressure monitoring pulse kind of is an indicator for your true heart rate. So you don't panic and like, oh yeah, the patient's heart rate is still there. It's like 80 or 90 beats per minute. So it's not really zero. So it kind of it continuously monitors your heart rate through the arteries. And withdrawal of the blood for exchange transfusion. This is mostly in, you can see it in kids when they have really high hemoglobin. You try to do the exchange transfusion. So you can easily access blood from them. So like you can withdraw like 5 or 10 mils of blood, and then you can infuse the 5 to 10 mils of saline through your other lines, because you can't give anything through the arterial line. So you just use another peripheral vascular cannula, or maybe a central venous cannula. So sites, where can you would monitor this arterial pressure? So you commonly use is radial artery. Then comes, you can use it as at the brachial artery and also the femoral artery, dorsalis pedis, and sorry for this, it's dorsalis pedis, and axillary artery. So most commonly used are radial artery and femoral. If in some cases, if you can't find a radial artery, then they go for femoral, and if you really can't find, then they go into the brachial. Dorsalis and axillary mostly are for, obviously, if you can't find all these three sites, then you go for dorsalis. Axillary mostly in cases of, like, I've seen it mostly in burns patients and stuff. So like when they have really bad burn skin, it's very difficult to find a proper site to insert a arterial line. So that's when you use axillary or sometimes also dorsalis pedis. So what are the complications? So we've inserted the catheter, the arterial line catheter, but there can be complications because you're putting something into the body. It's like a foreign body, right? So it can be accidental injection of the drugs, air, or thrombus. So you're not supposed to put anything through the arterial line. Arterial line is mostly for monitoring blood pressure and also to frequent sampling. So you can withdraw blood from it, but nothing to push through it. You can only flush the line with whatever saline is running through the system, but you can't put any drugs. Obviously, air is really dangerous because it can cause embolism, and thrombus, as it says, it's a clot. So any clot going into the artery can cause thromboembolism. So hypovolemia. Because it's sitting, so arterial line sits in, obviously it's in the artery, and it has a greater pressure. Sometimes what happens is accidental turning of the knob, or the cap. If the cap is not securely tight on the three-way tap, it can ooze, and then it can cause obviously hypovolemia because of hemorrhage or bleeding through the site. Then you have local damage to the artery. Sometimes they go spastic, and you can have digital necrosis, that is with the radial artery. Sometimes you can, maybe that's the only artery that is kind of functioning. Then you can damage the circulation towards the to the peripheries, so that can cause necrosis. carpal tunnel syndrome, hematoma, because the blood kind of can get pooled because you're rupturing the artery, and as I told you all, thrombosis. So this is how this is a whole set how the arterial invasive line looks like. So this is the arterial cannula. It's pink in here, but mostly it'll be red. It'll be a 22 gauge, like it'll be a bigger bore cannula, and it is connected to this high rigid tubing, as you can see. And then this is what I was talking about, is transducer. The transducer actually usually looks like this. Like I worked in a couple of places, like 2 hospitals, and they kind of look similar to what is this in the picture. And this is the connection. So this connection actually is for the monitor. So there's another cable connection through to the monitor, and then you attach it to this part. And this is another connected. This is another rigid part which actually connects to the flush solution. So it's a bit difficult when you see this picture. What is this? I don't understand. Is the questions going to come into your head? But once you start working with people who have arterial line, it becomes more easier to understand. So when this thing is connected, when this cable is connected to the monitor, you see this kind of a waveform on the monitor. So this is a normal looking or a normal arterial waveform. So what you can see here is there's a sudden rise. There's like a mountain kind of a thing, and there's a small notch, and then there's a deflation. So I'll explain what it exactly means, because tomorrow when you stand in front of the patient and check this arterial waveform, you need to understand if it's the normal one or the abnormal one. But at least you know that you at least know what is a normal arterial line to actually differentiate between the abnormal one from the abnormal one. So you can see this is the anacrotic limb. So it's what do I say is, do not get carried away with the names or the terms for it. It's a bit difficult, but understanding what it looks like is more important. So there is this anacrotic limb. So the anacrotic limb actually is like the initial upstroke. So the blood ejecting rapidly from the ventricle. Okay, and it goes up to the peak here. So this peak is called systolic peak, and then at this peak is the highest point. So your systolic pressure is kind of detected or determined through this peak. And then you have the dicrotic limb, as you can see, it kind of has a descending or a downward trend. So this is when the blood continues into the peripheral vessels, and the arterial pressure kind of falls down. And in this limb, you can find a small kind of a notch here, and that notch is called the dicrotic notch. And the dicrotic notch is usually it's a closure of the aortic valve. So this waveform is usually formed when the blood is getting into the into the aorta. Sorry. And this dicrotic notch usually tells you about the closure of the aortic valve. Okay, and then there's a steep here, and the end of this is the end diastole. So when the aortic valve actually closes and the diastole kind of begins, that is like again the relaxation phase starts. So this is kind of a normal arterial waveform that you can see. So when you see an arterial waveform like this, the shaded part which we have shaded here is usually determines your systolic stroke volume. So this is like a systolic phase. So at the peak, from the peak to the baseline, determines how much of stroke volume has determines the stroke volume of a patient. So this can, like the normal arterial form, or if there's an abnormal arterial form, can actually tell you how much of cardiac output is the patient receiving, like, just looking at the waveform. So these are some of the waveforms that you could see, like the abnormal ones, and when and in which disease conditions or which conditions these arterial waveforms can change. So mostly, um, when you see such swings in arterial waveform, we usually think, or it's in 1 to 5% of the clinicians usually give volume, because it can determine that the patient is in a hypervolumic phase. So they usually give volume in such, they have such swings in the blood pressure. In the arterial waveform trace. Here, in the next picture here, when you can see, is aortic regurgitation. So if there is any problem in the aortic valves, usually you can see this kind of a deflated or a deflected, not deflated, sorry, deflected peak, the systolic pressure, the systolic waveform is a bit deflected from normal. And if you see in an atrial fibrillation, usually when you see the ECG, it corresponds to what your arterial waveform looks like. So if you have an atrial fibrillation where your P waves or your atrium is just like constantly fibrillating, you get this kind of a waveform trace. And then you come down to this, there's an aortic stenosis. So as you can see, if there's any problem in the aortic valve, the aorta is kind of very constricted. There is a wide, systolic phase. So because it takes a lot of pressure to push the blood through the aorta. So you can see this kind of a waveform. The ECG can be normal, but then just to determine what kind of aorta or what's the if the aorta is diseased or not, you can actually make out from your arterial waveform. So sometimes being at the bedside as a nurse, it's quite very important to know what your waveform is actually looking like. Is it normal? If it's not normal, then you have to inform your registrar or inform your doctor that this doesn't look great. But before kind of informing, you can do some other steps, which I'll come down to. Nurse's responsibility, as I told you. Like, you need to understand what exactly the arterial wave looks like. So when you're looking at the waveform, if it isn't the right way, then you try to see the patency of the line. Sometimes what happens is the solution or the flush line or the saline which is being going in through the lines must be like dripping, or probably there's kink in the system. So that we need to check if the line is patent, and then leveling of the transducer. So it's very, very important to have the transducer leveled to the patient's reference point. So here always your reference point should be the phlebostatic axis. So usually we consider in patient as a fourth intercostal space, because it's very difficult to find the axis. You have to perform a imaginary line, and we take the fourth intercostal axis as your baseline. So like in the sense, an imaginary, the point of reference for leveling the transducer. So transducer has to be placed at the phlebostatic axis to zero it, or to read for the arterial line to read properly. I'll talk about the zeroing of the transducer, which is very, very important as a nurse when you're caring for such people, like especially with any invasive monitoring. It is very important to zero the line, to calibrate the line, and for the right reading to appear. Then there's something called square wave testing, as you can see. If I go back to the slide here, this transducer, when you pinch this transducer or this small apparatus where you can pinch the transducer, so when you pinch the transducer, it actually flushes the line. So when you pinch this, the fluid from this solution actually passes through this tubing and it flushes the arterial cannula into the patient. So when you do that, this is what happens. Like you can see a square wave coming up on the monitor. So if this is the waveform, and when you pinch it, there's a square test. So if this happens, that means your system or your arterial, your system is actually right. Like everything is proper, or there's no your arterial system is actually intact and it is doesn't have any errors. Sometimes you can also see a very over dampened trace, or there is an under dampened trace. So when you do this, you mostly in patients, sometimes like mostly you can see this over dampened trace. So it's kind of damped, and when you do a square wave or you pinch the transducer, there's a square wave test here. So it usually is wider because it takes a lot of effort, like pushes in a lot of solution in it, and you get a wider square. So that time you have to actually think what's wrong with my transducer set, or with what's wrong with my full arterial connection. So you kind of flush the catheter, or probably there's a kink in the catheter. Maybe the artery is in a bit of spasm, because artery going into spasm is quite normal because you're putting something, a foreign object into the artery, right? So it's quite normal to happen. So sometimes you just give like 5 minutes or 5 to 10 minutes for the spasm to go off, and then it comes back. I mean, it comes back to the right trace. Sometimes they're overshooting, as you can see, under dampened trace. And this is the square wave test that you can actually see in such cases. So coming to the zeroing, I will show you a video, and hopefully that should help to make you all understand. Hopefully everybody can see. Can everyone see this?
Yes.
Okay.
Good afternoon everyone. So today's session is about how to zero an arterial line. What are the indication, contraindication of arterial line? This is not the topic today. We'll discuss how to zero an arterial line and what are the steps involved. So before I have with me Sister Nitte and Sister Prito. They will help us to demonstrate how to zero an arterial line. But before going to the patient bedside, we'll have a short 1 minute graphical session or demonstrating how we do it theoretically. After listening to that, we'll go at the patient bedside. Thank you. You can see this is the typical arterial line setup. Here you can see the normal saline bag in the pressure bag. From this the flush goes here, down here to the transducer, and from here to the arterial line, PMA line to the patient. It keeps it flushing, otherwise the blood will come back. Now that's why its pressure is kept around 300 mmHg, so that even if the pressure is around 200, 220, this flush keeps the line flushing. From here you can inflate or deflate or adjust the pressure. Now this is the transducer. At the bottom it is one transducer cable is going to the monitor, and the other one is getting connected to this normal saline bag which is in the pressure, and from here it goes towards the patient. Means the it senses the pressure in the arterial line. Now, how do we zero this? How do we zero this? We will see in the next slide. But here it is important. You should keep in mind that the transducer cable and the line, PMO line, which is coming from the pressure vent, should face downwards, and the PMO line, which is towards the which is connected to the patient, it should be at the top. This should not get upside down, otherwise your system won't work properly. Now we'll see in the next slide how to zero this. So you can see in this diagram we have three openings. One is coming from the pressurized line, the other is going to from the patient, and the one which is open to atmosphere. Now when we are zeroing, we mean zeroing to the atmosphere. That means the pressurized line is 0 to atmosphere, transducer is 0 to atmosphere. So there should be connection between the atmosphere and the pressurized line. So the patient port should be off. We have put the patient port here off. Now this pressurized line is continuation with the atmosphere. Once you have connected these two ports, the off button is on the patient side. You press the 0 on the monitor, then wait for the 0 to appear on the monitor, and once it is done, then you turn this knob off to the atmosphere so that it is closed, and saline, pressurized saline is in continuation with the patient. As you can see here, you have turned the off knob to the atmosphere, and now pressurized saline is in continuation with the patient. Now as we look the theoretical part, we will go at the bedside and look how it is done. Now we are at the patient bedside. Sister Nitu, Pitto and Nidhi will demonstrate us how to zero a arterial line. Now before doing that, let's see how is the setup. Now here is the pressure bag. There is a saline bottle inside and there is a pressure gauge. It should be kept around 300 so that the pressure goes from above saline towards the patient, not opposite. And you can inflate, if the pressure decreases, you can inflate by pushing the air. You can release it with this knob also. Now at present it is 300, so we are not disturbing it. Now we'll see the transducer. This is the transducer. As you can see, this is the transducer cable. This is the transducer cable which is going downwards, and it is getting connected to a cable which is there. Cable is going to monitor. Okay. Now there is along with this cable there is a PMO line which is connected to the NS pressure bag which is hanging up there, and above this is the PMO line which is being connected to the patient. Always remember, the line which is connecting to the patient should always face upwards. This is mandatory. Now we have three openings, one towards the patient, second towards the transducer, and this is towards the atmosphere. Sorry. So what we have to do, we will zero to the atmospheric pressure. We will zero the transducer to atmospheric pressure so that it can record what is the actual pressure is with the patient. How we will zero? This is when it is recording, it is in this stage. So sorry. At present this is off and these two are connected. This is the off one. Here it is written off. This is off. Now what we will do, we'll turn it off towards the patient. So now this transducer and this atmospheric port, they are in connection, and at this stage we'll zero the monitor. Sister, can you press 0 one time? See, this is, she has pressed the zeroing and the 0 will appear. Now it's being zeroed actually. What we will do, now at this stage we'll turn the knob, we'll switch it. Now we have turned the off towards the atmosphere. Now these two are connected and we will have a reading on the monitor. See this. So this is the way we zero an arterial line. If you have questions, you can ask on the forum. Thank you.
Great. Let me share my screen again to the presentation. So as in the video, they showed you how to zero it. It's quite similar to what it's actually similar to what we usually do in day-to-day ICU life. It's ensure the transducer bag or the pressure tubing and flush are correctly assembled. So if there is air bubbles in the system, you usually can't really read the arterial trace properly. Another one is if there's an arterial line, if the arterial line is connected to the bag, then you have to ensure that there is 250 to 300 millimeter of mercury of pressure in it, because when there is the right amount of pressure, the solution actually goes into the system, like into the tubings, and it keeps the patency of the bag. When I say heparinized saline, it doesn't mean that there's a lot of heparin. It's a very subtherapeutic heparin. So we put like at every beat, or in the sense every hour, there will be 2 units per mil. That means there will be like 2 mils or 3 mils of solution being pumped into the system. And in my place, in my ICU, we have kind of eliminated the bag at the moment, but most of the places, like in the theater or in the emergency places, you can still see the bag. But because I work in the ICU in the pediatric sector, 2 to 3 mils every time to a pediatric patient kind of is really like a lot of amount, when if you're calculating if the patient is only like 3 kilos or 4 kilos, it is a really great amount, and it kind of includes the total allowance of the patient, like fluid allowance that patient can have per sometimes it's per hour. So that's why we have cut down and we have made it into a syringe kind of a system. But the pressure bag is eliminated and everything goes into the syringe, and syringe goes into the syringe pump, and then it is kind of the pressure is applied by the pump, similarly as the heparinized bag here in the pressure bag. So that's only, I think, difference that my hospital has made, but then it's only in the ICU where I work. It's not every places. So it's most of the places still the pressure bag, and you still have to pump it up, just like a sphygmomanometer, like you pump it up to the pressure. Next one is you place the patient flat, if possible, if the patient can be flat, or sometimes you can keep them up to like 45-degree angle, and have the transducer level by a scale if you have a big long scale, or sometimes you get a mercury leveler. So you use that and level the transducer to the axis, that is the fourth intercostal space. And as I mentioned, it's off to the patient, open to the air. That's how we usually do it. So you open it to the atmospheric air. When you're doing this, you're actually leveling, you're leveling, it is actually equating to the current atmospheric pressure. So it kind of, when on the monitor, it displays at 0, and that's when you are actually zeroed, or you can say you have leveled to the atmospheric pressure. And then you close it to the patient, and in the sense, you open it to the patient after zeroing, and then you can see the right reading. So if you want to if you want to get the right reading, or if the patient has been moved from one place to the other, in the sense from the bed to the chair, then you have to level it again, and you have to zero it again. So in my setting, like they usually say that you do zeroing every 4 hours, but with the new systems coming in place, like there are because of research, there will be different kinds of sets coming in, where the technology has improved that you don't have to do it every hour. It's just like once per shift. So either you begin your shift, you do your zeroing and calibration, and it is good for your 6 hours or a 12-hour shift. And then you might do it again if the patient is moving or has been transported somewhere, like out of ICU, then you zero it and calibrate it again. So you have to mention, as I mentioned, patency of the catheters should be maintained. Seeing there's no clots in the circuit, or there's air bubble, there's no air bubble, or if the line is kind of tampered, or it is that you can see a clot, kind of take the clot out and then let the flush work through and flush the line again. So every 4 hours or whenever required, but we do it once per shift. Check for blood pressure accuracy. Sometimes what happens is they can be dampened, as I mentioned before. You can have an over dampened or under dampened arterial trace. In that cases, you usually can have a non-invasive blood pressure being taken. We still do it to compare the arterial line pressure, because sometimes what happens is if there's a system glitch, then your non-invasive blood pressure can actually tell the give you a semi-accurate blood pressure of the patient. But if there is like a discrepancy of like if the non-invasive blood pressure is reading like 20 millimeter above, or like 30 millimeter above, then you probably must have to think that probably your arterial line is not okay, it's not right. Then you check the patency again. So when you're having an arterial line in, you have to perform the neurovascular obs, or you can say neurovascular observations, which is like every second to 4 hours. Sometimes you don't have to document it, like we don't document it every hour, but we actually check on their hands. Like if they're having a radial arterial line, then you need to check their hands. If they're having a dorsalis pedis artery, then you need to actually check their finger, like the toes, to check if there is peripheral circulation. So you check for this. So you check for pain, you check for pulses, especially by the cap refill. They can go pale at the digits, as you can see in this picture. They can have sometimes numbness or tingling, which we call as paresthesia, and also you can see sometimes they can have paralysis. So checking all these 5 P's is quite very important. I know sometimes it becomes very difficult. Like, to be honest, on a daily basis, on a very busy shift, you can't do this neurovascular obs every hour, but at least check for 2 to 3 hours if their fingers or their toes are quite, they're not going pale or they're not getting mottled. There have been incidences when we have removed the arterial lines and they have got hematoma, or you usually they can go a little bit mottled, in the sense the color changes of their hands or of their, especially their palm. But then you just give them a bit of rest and have a tight pressure bandage around the site, kind of can help the hematoma to come down, and then after a couple of hours they regain their color, and then they usually return back to proper normal circulation. But sometimes the hematoma can take up to like the hematoma to really go down. It might take about like 24 hours as well sometimes. So next coming, that was with the arterial arterial pressure monitoring. The other thing I have not discussed is removing of an arterial line. I'm sure still in Indian hospitals, the nurses can do it. We just remove the arterial line. We just put a pressure, as I already mentioned to you. In my settings, we usually like when we don't need a arterial pressure monitoring, like if the patient is kind of um, is stable and doesn't require continuous pressure monitoring, like continuous blood pressure monitoring, continuous frequent sampling of the bloods, then we decide on taking out. So we decided on a morning round, and we take it out just by like any other cannula. So, but you give a nice good pressure while you're taking it out, and you need to have a proper blood pressure, like a non-invasive blood pressure taken before you take out your arterial line. So, and then you just check for the site every hour or two after you have taken the line out. So next coming to the central venous pressure monitoring. So I think everyone's heard about CVP, so the central venous pressure. So it's a pressure in the superior vena cava or the right atrium to provide information about the fluid status and the right ventricular function. So usually tells you about the filling pressures. That's what we say in medical jargon. So the normal range can be from 2 to 6 or 2 to 6 mercury, millimeters of mercury, or it can be 3 to 5 centimeters of water. In our hospitals, we usually go about with millimeters of mercury. Either side of the spectrum would actually say if they're really low on the CVP, it means that they have a bit of hypervolemia, or if they're really high on the pressures, then it is like hypervolemia. So it is like they're probably overloaded with fluid. So as they said, as it says, like central venous line assesses the right heart filling pressures. You can also infuse vasoactive drugs because most of the time it's harmful, or say it can cause extravasation of the drugs when you give the vasoactive drugs like adrenaline, or if you're giving nitroprusside, or if you're giving any kind of other drugs which are which will increase or decrease your blood pressure. So these vasoactive drugs are better to be given through your central venous lines. Also, some of the electrolytes like calcium and magnesium, when you're giving them as an infusion or also as like a bolus drug, you usually give it to the central line. Infusion of the hyperosmolar fluids, like if you have to give we usually take central line. If we have an access of central line, then we usually give like a lot of fluids. If we have to give a patient like more than required, like we estimate the volume here as 5 ml per kilo or 10 ml per kilo of fluids, and you have to give it rapidly, then we usually take a central venous line to give any of the large volume of fluids. So, and also to understand mixed venous saturations through the sampling. So, mixed venous saturations, what I mean by is the understanding the venous saturations. So, when you're doing a blood sampling or you're doing arterial blood gases, you get the arterial oxygenation, and when you do it from the central line or from any other peripheral line, you get the only from any other venous line, you actually get the venous saturation. So you compare both to understand how's the oxygen saturation, or say perfusion, or the delivery of oxygen happening at the peripheral level. So that's more important. So you usually do the blood sampling from the CVL line. So as I mentioned, increase in CVP can happen when there is hypervolemia, so a lot of fluid. If there is a right ventricular failure, can happen in pericarditis and cardiac tamponade. So cardiac tamponade is something I would want to tell you. We usually have kids, because my center where I'm working at the moment is mostly a tertiary cardiac center for the kids. So we get like really complicated cardiac surgeries done at our ICUs, and we usually can face this cardiac tamponade. So when they come in with the central line, and if the central venous pressures are kind of increasing, it kind of means that there is a buildup of fluid around the heart. So when there is a buildup of fluid around the heart, your heart gets compressed and your pressures kind of starts increasing. So the CVP and the heart rate is one of the first indicators to tell you that your heart is tamponading, or in a sense your heart is kind of, it's constricted and it can't give a proper cardiac output. In that cases, what the next step would, in a sense, the next thing which you can see on the monitor is hypotension. So your blood pressures can fall rapidly, and then you go into a situation called cardiac arrest. So to prevent any cardiac arrest, you have to keep eye, especially if they come after cardiac surgery, you need to keep an eye on their central venous pressures to see that they're not increasing in a rapid fashion, or in hourly monitoring of CVP is regularly important at that point. So when you have decrease in CVP, it means that patient probably is underfilled, may need more of fluid, maybe in shock, or if there is venous venodilation, if the veins are really dilated, also you can have a decrease in CVP. So in that case, sometimes filling them really helps. I always say my new staff members that a happy heart is a filled heart is a happy heart. So you fill them adequately as required, and they kind of give a good cardiac output. This is a setup of central venous line. As you all can see, there is a catheter tip, and they can come in 3 lumens, they can come in 2 lumens, can come in 3 lumens, they can come in 5 lumens. But for daily purposes, and in commonly used as a 3 lumens. So they all open at a different as you can, I don't know if you all can see, but there are small holes here, this one. So towards the tip, it's always distal. So the distal port, the brown lumen opens on the distal port, and then you have the medial, which is the middle, and then you have the proximal, which is farthest away from the catheter tip. So usually we kind of attach our CVP on the distal or on the proximal. If distal is being used, then it's proximal, but CVP monitoring can be done on either of them. Next one, insertion sites. So this picture kind of depicts all the insertion sites. So we have internal jugular vein, then we can have the subclavian vein. There is a peripherally inserted catheter, so a central catheter. So this, when inserted into a bigger vein, especially like the brachial vein, they can actually, the tip is really long and it extends up to the superior vena cava, and it sits around this. With femoral vein catheter, so you put it on the femoral region, and then it extends up to the inferior vena cava. So it can go up to, in our kids, sometimes they just go and sit into the, because the tip is so long, sometimes it goes and sits inside the right atrium as well. But then you need to know what pressures you're really monitoring at the moment. Are you really monitoring the central venous pressures or the right atrium pressures? We'll come to those. So just like arterial line has a waveform, similarly CVP has a waveform. So according to the ECG, you can get a CVP as well. So if there is any problems in your ECG, your CVP also will show problems. So to understand what's the normal CVP trace, we'll concentrate on 3 waves. That is A wave, which you can see at the peak here, then there is C wave, and there is V wave. So A wave is always caused at it's a peak atrial contraction. So when the atrium are contracting, you get a wave. So it follows with a P wave on the ECG. If you all know normal ECG, it is P, QR, a QRS, and a T wave, right? So P wave is always an atrial contraction. So it always follows after an atrial contraction. You will get a wave. Then you have the C wave, which you can see a small kind of a deflection here. That is the RV, or the right ventricular contraction. Okay. And then you got the V wave, which is here, which is like an passive atrial filling. That is also against a closed tricuspid valve. So when the tricuspid valve opens, you kind of can get the V wave, and then you have again the A wave going. It's kind of a systole, and this is kind of an diastole. So contraction phase, and then a diastole phase. Then there's another contraction. So this way it continues. So you will see a CVP trace on the monitor. Sometimes in real life scenarios, sometimes you really don't get a proper CVP trace, to be honest. Like sometimes they're very, very clear that you can see an A wave, you can C wave, and you can see a V wave. But at times, you really can't see a proper CVP line. It can be because sometimes there will be fluids administered to the same CVP line. In real life scenario, what happens is you can be giving a lot of fluids through the system, to the CVP line, and that's when you don't really get a trace on the CVP. So at that point, you have to be mindful and let others also know that, like your doctors or your other intensivists, to know that there's something going through the CVP line, and that's why I'm not getting the waveform. When can you see disturbances in the waveform? As I mentioned, A wave is usually in the systole, like when there's a P wave contraction. If your atrium doesn't contract properly, or if they're fibrillating, they can be absent. Or if there's a atrioventricular dissociation, in the sense there is no proper communication from the atrium to the ventricles, your air waves will be like really increased. And in the tricuspid regurgitation, so like if there is the tricuspid valve, which is on the right hand, on the right, in between the right atrium and the right ventricle, if the tricuspid has an issue, you will be replaced with large C waves. It's, to be honest, you should really know if there is issues in your wave. Like sometimes they can appear like a sawtooth, or just like if you have seen a VT kind of a waveform, it kind of appears that way. Sometimes it's because your tricuspid valve isn't working, or sometimes if there's no A waves, or if there's deflections, then you can see atrial fibrillation. But you can see that also on your ECG will appear similarly. So in such cases, it's better to know what's your normal CVP line, CVP waveform, but it's also important to know your numbers of your CVP. So CVP pressure, central venous pressure, is also very important. So zeroing, calibration, same as your arterial and your CVP line. So usually they have a pressure bag, and the transducer should be sitting around your phlebostatic axis, that is the fourth intercostal space, and you need to level it to that axis and then zero it on the monitor. You can see a flat line coming up when you zero it, and then you try to get the reading after turning the knob open to the patient. So similarly, have the pressure at 250 to 300 millimeters of mercury. Place the patient flat if possible. Patency of the catheter is still required. Sometimes there can be bubbles in the line. You need to find out if the bubbles, and take the bubbles out by aspirating it, and then level and zero it again. Understand the CVP graph if you can see one, if there's nothing going through the CVP line, because CVP line you can also give your drugs through that. So be mindful and observe for any complications that can happen, and troubleshoot, as I told you. See if there is any kink. Most likely, most of the time, it is the kink that causes issues. So you remove the kink, in the sense that it'd be just like, kink at one particular tubing. Relieve that kink. Sometimes it'll be close to the patient and you can't see a CVP line. Open it to the patient. If there is any clot, you try to aspirate it, clear it, flush it. So all these things, as a nurse, we will be doing at the bedside. The complications, nothing goes away if you're putting invasive line in a patient, right? So there will be complications like hemorrhage, infection because of foreign body. As I told you, catheter occlusion. There can be, if you don't use, or if you're not flushing the line properly, or in the sense there's no continuous flush, the catheter can block. And this is like an everyday scenario for us, like at the bedside. Sometimes when you want to give any drugs to the central venous line, the lumens will be blocked, and then you need to kind of open the lumens by giving a bit of heparinized saline, which actually unblocks or dissolves the clot. Then sometimes what happens, because of the patient movement, they can have a catheter displacement. You can induce air into the patient if the line is open and it's not a closed circuit. Can cause cardiac arrhythmias because it's obviously sitting in the right, in the superior vena cava, and it is getting into the right atrium. So it can cause a little bit of, if the catheter has migrated, it can cause arrhythmias. Pneumothorax or hemothorax. Coming to the next section is pulmonary artery catheter. So well, at my first job, when I worked in Pune in one of the hospitals, when I was working as a cardiac recovery nurse, I had to deal with pulmonary artery catheters a lot. But when I came to Australia in my pediatric hospital, they usually they don't put this catheter in the kids. I'll tell you why, because it's very, very long, and my kids are very small. So obviously kids are very tiny little creatures. So this catheter would actually probably, go into the heart. They might come out of the heart. So you usually don't put it in the kids. But this pulmonary artery catheter, as its name says, it sits in the pulmonary artery, and it actually gives the pressures of the pulmonary artery. So there's another name for this. Swan-Ganz is after Dr. Swan and Dr. Ganz. So it was founded in 1970, where Dr. Swan wanted a catheter to determine the pressure of the pulmonary artery. And on the side, Dr. Ganz was working on finding out the cardiac output through a method called thermodilution method. So both together built up this catheter in 1970, and it's named after them. So it's called Swan-Ganz catheter. So how does the Swan-Ganz catheter look? So Swan-Ganz catheter looks like this. So it's mostly yellow, and the catheter looks yellow in color, and it has 4 ports or 5 ports, but usually comes in a 4-port system. So it has a balloon tip. So balloon tip is usually because when they insert a catheter in a patient, it usually it floats around. It floats in with the help of the inflated balloon, just like as if the boat is on the in the sea or in the ocean, it passes. It just floats around. Similarly, the balloon, when it's inflated, it passes into the circulatory system. With the help of the balloon, it goes into the system from the aorta, from the superior vena cava into the atrium, right ventricle, and then PA. I will show you a video and you'll understand better. So it's 110 centimeters long, inserted into the large vein. It can be internal jugular vein or a subclavian vein, and it floats into the pulmonary artery. So the proximal port, as you can see, it measures the right atrial pressure, and you can also give drugs and fluids. Distal port is actually, it measures the pulmonary artery pressure or the mixed venous saturation. They all open at different ports, okay? That's why they are named proximal and distal port. And then you have a balloon inflation port, which has a 1.5 mil syringe connected. This kind of inflates and deflates the balloon. It also measures the pulmonary capillary bed pressure, which is a very important pressure to know. Thermistor port, which measures the cardiac output. So this is the thermistor port. So at this connection, if you see a black line kind of a thing, there is a thermistor present here, which actually measures the temperature as well. We can come to that. Next one, catheter insertion and position. So as you can see here, the catheter inserted to the superior vena cava, or sometimes it's mostly superior vena cava, and it enters into the right atrium, and then it goes into the right ventricle, when the balloon is inflated, it by the help of the blood flow, it is actually pushed. So they don't push the catheter in; it usually goes in. It's guided in through the blood flow, and it goes into the pulmonary artery and then wedges here because the balloon is already inflated. So it kind of sits around the pulmonary artery because of the diameter. So it's already inflated here and sits around here. So at each chamber, you get a different waveform. So when they're inserting here, they're usually it's a fluoroscopy or a guided procedure. So on the monitor, you can see these kind of waves. So if it's going to the right atrium, it gives you this kind of a pressure. So you can see the A and C and the V wave, and usually they are like 0 to 8. And then you can see right ventricular pressure, which is about 20 to 25. The diastole of 6 to 12. Then when it goes into the pulmonary artery, it gives you this kind of a waveform. And when the balloon is already inflated and it wedges, you can see capillary wedge pressure. So I will show you this video. It will make you understand a lot better. Hopefully everybody can see.
Yes.
Us about the pulmonary artery catheter, also known as Swan-Ganz catheter. A Swan-Ganz catheter is usually 110 cm in length. A balloon surrounds the tip of the catheter. Catheter is marked at 10 cm increments from the tip to aid insertion. Usually there are 4 ports in the PA catheter. First is the proximal infusion port. Its lumen terminates 30 centimeters from the tip of the catheter. This opening lies in the right atrium when the tip is in the pulmonary artery.
And you can see
so
the
this
tip
port can
over
monitor
here.
right atrial pressures,
Over
that is central
there in
venous
the
pressure.
PA.
It can also be used to give fluids and drugs. The second is the distal pulmonary
And the
artery
next
port. Its
tube
lumen terminates
is the
at the
distal
tip of the
PA port, as I
catheter.
explained.
So when in position, this port is used to measure pulmonary artery pressure and mixed venous saturation. Third is the balloon inflation port. Fourth is the thermistor. Its
That's the
lumen
balloon
terminates
inflation,
4
that's the
centimeters
thermistor port.
proximal to the tip of the catheter. It is used to measure cardiac output using thermodilution technique. The catheter which we are going to see does not have the thermistor. The PA catheter has to be flushed with saline before the insertion. So when the distal pulmonary artery port is flushed, the saline comes out of the tip of the catheter.
Can you hear by any chance?
Next, the proximal infusion port is flushed. The proximal infusion port is flushed. One can see the saline coming out of the opening at
So
the
they
30
are pushing the
centimeters
fluid,
mark,
Yes.
as
and you
discussed
can
earlier.
see
The balloon
opening
of the
through here.
catheter is checked by inflating 1.5 ml of air using the syringe as shown. The balloon is used to guide the catheter into pulmonary artery by the balloon flotation technique. The balloon is also used to wedge the pulmonary artery to measure the pulmonary capillary wedge pressure, which is an indirect measurement of left atrial pressure. PA catheter is inserted after placing an introducer sheath in the internal jugular vein. The side port of the introducer sheath can be used for rapid infusion of fluid.
Can I just ask, can you hear the video or?
Yes,
Yes,
we can.
I can hear. Yes.
Yeah, you can hear the video? Okay.
Yes.
Let's open up the heart to see the position of the PA catheter in relation to the internal anatomy of the heart. Pulmonary artery catheter is then gradually inserted into the sheath. It should be noted that a pressure monitoring transducer is attached to the distal pulmonary artery port to observe the continuous pressure waveforms. Once catheter is inserted till 20 centimeters mark, it usually crosses the tip of the insertion sheath. Now the balloon of the catheter is inflated with 1.5 ml of air. So now the tip of catheter floats in the blood, and aids in the correct placement of the catheter. The catheter is advanced till the right atrial pressure is obtained in the monitor. In the right atrium, the pressure usually averages less than 5 mm mercury and fluctuates between few millimeters mercury. When pushed further it reaches the right ventricle. The systolic pressure increases to about 25 mm mercury, and diastolic pressure remains same as the right atrial diastolic pressure. When the catheter tip reaches the pulmonary artery, the systolic pressure is similar to the right ventricular systolic pressure, but there is increase in the diastolic pressure, to about 10 mm mercury. It is due to the closure of the pulmonary valve during diastole. When the catheter is pushed further into one of the branch pulmonary artery, the balloon wedges, and it measures indirectly the left atrial pressure. The mean pressure is about 10 mm mercury, and the waveform is similar to that of right atrial.
See, this is what I was mentioning about wedge pressure. When I told you pulmonary capillary wedge pressure, so this is kind of can give you a pulmonary wedge pressure when the balloon is inflated over there. Just be mindful because I'll be speaking about it later on. So,
Pressure. Once the wedge trace is obtained, the balloon is deflated, and return of pulmonary artery pressure trace is confirmed.
and then you get the
If the PA trace is not
waveforms
obtained,
back.
the catheter is withdrawn slightly, till the PA trace appears. Usually the right atrium is entered at 25 centimeters, the right ventricle at 30 centimeters, and the pulmonary artery at 40 centimeters. The wedge pressure can be identified at 45 centimeters. These are only approximate measurements. Once the procedure is complete, chest X-ray is taken, to check the position of the pulmonary artery catheter. Hope this video was helpful. If it is, please do share it with your friends.
Cool. Let's go back to the presentation. So you all understood how it is placed in, and then you saw the entry site, and the video kind of actually helped you understand waveforms at different chambers. So it's just a pictorial depiction of the waveforms when they go into the pulmonary artery. So this is mostly what you can see on the monitor when it is rightly placed, and if it is kind of migrated from there, then you will have a ventricular pressure, and it kind of alarms anyone because there's no dichrotic notch, as you can see here. And this dichrotic notch, I will tell you how it is formed. It's because of the pulmonary artery, pulmonary valve closure. Just like in the arterial waveform, you have a dichrotic notch, and that's because of the closure of the aortic valve. Here it's because of pulmonic valve. So if there's any migration, sorry, I'm skipping, but it's very important because these lines can migrate, and because of any reason, like you can accidentally pull it through with when you're pulling out some lines, and you can accidentally pull it out. So you can kind of see these waveforms. So there can be a right ventricular pressure waveforms, or if they've migrated really like into the right atrium, then you can see these kind of forms or waveform. But usually you can see the pulmonary artery pressure waveform. Next one. This is just a chest X-ray of a patient who has got a pulmonary catheter inserted. And you can see the tip sitting over here, and that's the pulmonary artery. Indications. Or when would you have a pulmonary artery catheter put in? So in septic shock patients who are very, very unresponsive of fluid resuscitation, you would want to measure their pressures, especially with the cardiac output. Then you put a PAP, or a pulmonary artery pressure monitoring line. In refractory shock, in cases of assessment of pulmonary edema, because this can cause pulmonary hypertension, which is a very important condition that you would see in a patient, especially if they have a heart or a lung disorder. Kids with congenital heart disorder, and also when they come out from the cardiac surgery, but we don't put a Swan Ganz in them. We have another line which kind of sits intrathoracic, so kind in the sense like they open the sternum, and when the sternum is open and the line is directly inserted into the pulmonary arteries in the PA lines. So we don't have a Swan Ganz for the kids, so we directly get the pulmonary artery pressure. Multiple organ failure, optimization of cardiac index. As I mentioned to you earlier, your cardiac index is obtained from the cardiac output, and usually it sits around like 2.5 to like 3.5 liters per minute per meter square. So you it usually tells you the cardiac index or also the cardiac output, and especially in the cardiac shunts, especially this is with the cardiac disorders, and then if they are really high surgical patients, then for their perioperative stay, they usually have a PA line inserted. So pulmonary artery pressure monitoring. As I told you, assess fluid status. It tells you about the cardiac output, why it is used for, and tissue oxygenation. As I told you, it gives you mixed venous oxygenation, so it tells you the venous oxygenation, and oxygen delivery and the consumptions also, if you want to know what it is. And then also it tells you about the systemic vascular resistance and also the pulmonary vascular resistance. So to know all these, you need to have a PA line. We say, as a medical jargon, we use it as PA line. So the pressures, normal pressures for them, as arterial or blood pressure has its systolic and diastolic and a mean pressure. Similarly, PA has systolic pressure, which has to be around 18 to 25. Diastolic pressure sits around like 5 to 15, and a mean pressure sits around like 12 to 16. And a wedge pressure, as you saw, the wedge pressure will be around like in the lowest numbers, like 8 to 12. So if there is any increase or decrease in the wedge pressure, it kind of tells you that it tells you about the fluid status, or if the patient is overloaded or probably underfilled. Accordingly, you can give fluids as well. Next one is right atrial pressure, because obviously when you're putting in through the system, the one port, the proximal port, actually tells you the right atrial pressure if you connect it to the monitoring. And then you get the cardiac index, and I'll show you how they do that. And it tells you about the cardiac output. This is the wedge pressure. I'll skip that because we have already seen the wedge pressure. So next thing, we measure the cardiac output. So this pulmonary artery line or the Swan-Ganz catheter has a special feature which actually tells you about measuring the cardiac output. So there is a thermodilation technique that they use, in which they infuse cold saline. In some hospitals, they use 5% dextrose. So they induce up to like 10 mils, and they like push in 10 mils, and when it goes through the Swan-Ganz, it mixes with the blood, and then it passes to the ventricle, and it goes into the pulmonary artery, and it cools the blood. So it usually tells you the temperature as well as the cardiac output. If you connect it to the monitor with the module, it gives you the cardiac output, and it gives a nice graph. And this technique is called thermodilation technique, and it gives you this kind of a graph. So there would be temperature change, and with what intensity or like with what force that you're pushing in. Usually it is a faster push. This, but not like a really very slow push because it doesn't give you that graph then. So normal cardiac output usually should give you this graph. In a poor cardiac output, it takes a lot of time to actually push the blood out. And in tricuspid regurgitation, it's a poor cardiac output as well. So you can't see because there will be backflow of blood, so you can't see a proper cardiac output. So here in this video, they show you how to do a cardiac output. Hopefully everybody can see. And here, not here, I don't think you can hear. So when they inject, this is how it comes out. And you can see this thermistor, this black or brownish color filament. That is the thermistor, that is the temperature detecting. So when you push in the cold fluid, it usually tells the fluid's temperature as well, which is passing in through. And when it passes in through it, it gives you that graphical representation. And this part is called the CO, or the cardiac output. With the next slide. This is how it appears on the monitor. So to all the calculations that have been done comes up once you push in the fluid. It usually gives, you have to put the height and the weight of the patient, and the BAC is calculated by the, obviously the monitor. And then when you push in the fluid, it actually gives you the cardiac output over here and the heart rate and the blood pressures and everything, which is already detected at that point of time. Kind of comes up on the system, and then it calculates PA pressure, systolic, diastolic. So when I was in Pune, when we didn't have to do it, the registrars had to, the doctors did it. But apparently in Australia, in other countries, it's the nurses who are accredited or who are deemed competent to use a pressure arterial line, a pulmonary arterial line, can do this pressure monitoring, pulmonary pressure monitoring. But we used to do it like when we became seniors in our ICU in Pune. Our doctors used to allow us to do it under their supervision. So we used to like calculate our patient's cardiac output or SVR or PVR. Depending on SVR, if the SVR is low compared to what it has been, they usually tell you on the sides over here. If you can see the normal numbers. So according to that, if the patient's SVR is low, then you have to think that probably, and if the blood pressure is kind of seeping down, then you think of adding a little bit of medications which will increase the SVR, or probably if their cardiac output is low, or it needs and the PAP is low. So you think of giving more of fluids because obviously their pulmonary artery pressures are low, and there are the RA line or the right atrial pressures, if you monitor, and the CVP pressures are low, then you kind of give them a little bit of fluid. But here, when you see this patient's CVP is a bit higher, so, and his PA pressures are really, really high, so you would not give any fluids at this point. You try to decrease the PA pressures by giving some antihypertensive medications, which I will come to, and I will tell you all what it is. So usually they perform like 2 or 3 times. So they do like, I think they do 3. We used to do 3 cardiac output cycles on a patient to determine, and we take the mean out of the both, and then we decide this is the cardiac output of the patient. So sometimes they are done in like two consecutive times. So if you see here, it's at 6:09 and 6:09. They have done two, and they would determine which is, and if it's quite similar, then they take it as 2.6 as the cardiac index, or the cardiac output being whatever is the cardiac output that has come out during that time. Yeah, so they do like 2 or 3 times and they take the mean out of the 3, and that's your cardiac output and cardiac index. Nursing responsibilities. So obviously full assessment is basic thing that you need to do. Zeroing and leveling the transducers similarly as your other arterial, other pressure monitoring lines. Ensure the waveform is correct. As I said, there is a waveform for the pressure, pulmonary artery pressure. So you need to see if they are sitting in the right chamber or not. And the scale. So what do you mean by scale here is, on the monitor, usually you get an option of optimizing or putting up to the to a particular scale. So if you want the waveform to be bigger or smaller, depending on that, but you need to optimize it before doing all this, like before doing this cardiac output method, this technique. Before even analyzing the cardiac output, you need to optimize it, not to optimize it just as you're doing it. But this also matters because sometimes when the waveforms look really bigger, as I told you, when they look really bigger, it means there's some issues with the patient. So you need to keep it according to what the mean blood pressure has been, or what your systolic blood pressure has been. When you can see here, there's a systolic alarms set over there for this patient. So if you're monitoring the systolic pressures of the patient, then you set up the alarms and also the scale according to the systolic pressures. If you're looking at the mean blood pressure of the arterial blood pressure, then you set up the scale. These lines, what you can see is a scale. So you set it up according to the mean arterial blood pressure. So, and you set the alarm limits as well according to what you want. So that's what it means by scale. Monitor the PA trace at all times, because the migration can happen. If it's sitting in the RV, that is the right ventricle, it can induce ventricular tachycardia, which can be really, really fatal. Document on your flow chart that what's the sheet site, and also what is the length it has been at. And then see this one here. Each has a difference of 10 centimeters. So from one line to the other line has a 10 centimeter gap. So it is like from 10 centimeters to 50 centimeters, and then you accordingly. So document the PAPs, or you say pulmonary artery pressures hourly. Set alarms, as I told you, appropriately to a systolic alarm to a value above the patient's wedge, so that it doesn't if something happens, there's a spontaneous wedging happening. Spontaneous, the balloon can inflate and you can wedge the pulmonary artery, which can cause rupture. So you need to be mindful that your alarm limits are above the patient's wedge value. Never inflate balloon longer than 15 seconds, or it's also said like 2 respiratory cycles. So when you're inflating the balloon, it should be like in 10 to 15 seconds and not longer than that, because you're wedging, you're actually blocking the blood flow. Leave the balloon syringe with no air and tap open to the syringe, and perform cardiac output studies post-op and then 6th hourly as per your registrar. So it depends on hospital to hospital, the policies. Some people like to do it every second, third hour when they come post-operatively, and then thereby you increase your time from 6 hourly to like 10 hourly. And then inspect the sheet insertion site for infection, and change dressing whenever as per protocol. So in my settings, we change dressings of the central line every week. So 7 days, after 7 days, you need to change the dressing. That is to maintain the infection control. And if it is soiled, they do it before that. Complications can be, as I told you, spontaneous wedging of the balloon. The balloon can just inflate by itself, and it can cause life-threatening complications. It can cause a rupture, so you need to immediately inform the registrars or the doctors on duty. Infection, arrhythmias, they can go into complete heart block when you're inserting the catheter. Air embolism with any kind of invasive line. This is very common. Like common in the sense the embolism can happen. Air embolism can happen. So you need to be very mindful while you're inserting, and also when you're removing the line. Thromboembolism, pulmonary infarction, that's because sometimes when you're kind of, if the balloon is being wedged, it can cause infarction. And pulmonary artery rupture, balloon rupture can happen, and valvular damage. And that is endobronchial hemorrhage. So that's kind of all with the invasive monitoring of hemodynamics. Coming to the next section is, these are the these are as a result of your invasive hemodynamic monitoring. You can actually find out the markers of perfusion. So this is very important. And when you think about a patient who is really, really sick, or who is very, very unstable hemodynamically, these are the markers that you actually look into to kind of optimize their cardiac output. Some of them are reversible, but if they go into later stage and hours of no correction, then obviously they end up having cardiac arrest. So to prevent cardiac arrest, you need to optimize all of these monitors, like all of these numbers, especially your SATs, your pulses. If they're getting 30, you need to know why they're getting 30, because these are the first markers that you can see. Your color of the patient. Never underestimate, especially when if you're working in the pediatric side. I see the color of the patient really changes rapidly. Like you can see them getting bluer, and then if they have any pulmonary hypertension, which can be because of their cardiac disorders, they may be having cyanotic heart lesions. You can kind of see them getting bluer, and then you need to treat them immediately by kind of because if they're crying, they go blue as well. So you need to kind of calm them down, give them some sedatives, give them some painkillers, calm them down, and their pulmonary hypertension resolves quite well. Delayed cap refill, cold extremities, all these are kind of markers of your perfusion. Lactates. So lactates are another thing which is very, very important, especially when you have a patient with septic shock or with any kind of surgical history, or if they come post-operatively from a surgery, or also cardiac, also any kind of surgery, and also cardiac surgery I'm talking about. So lactates are produced, or lactic acidosis happens when there's poor perfusion. So there's anaerobic metabolism that happens, and as a result, the lactates increase. So we usually in our ICU settings, we keep lactates below 2. Something above 2 or 2.5, we kind of try to treat it by seeing what's the cause of lactates. If it's poor perfusion, if the patient needs more fluids, then you give a little bit more fluids. Sometimes it's the hemoglobin that has caused the lactates to go higher, because hemoglobin obviously carries a component of oxygen. So you need to see that if the patient needs more oxygen or more fluids, then you kind of resolve. It can be reversed at an early stage, especially immediately in some minutes. But if they are not treated for a long time, the lactates can go to 4, 15. Don't know. We received a patient recently last month whose lactates were 30. At this point, you always think the kid is really, really sick, or sometimes they even can die out of lactates being so high. But thankfully, that kid was in the emergency department and they could treat it, and then they sent the kid to the theater. Um, they intubated this kid, and then they started infusing a lot of fluids, and they understood, and then the lactates were kind of resolved. But patient obviously had another underlying heart issue. So the other management is later on when like that kid the later on had was on like a high uh, like life support, like extracorporeal oxygen membrane, like membrane oxygenation, that's called ECMO. But that's a later stage. So to prevent all these cardiac arrests and stuff, you need to kind of resolve all these markers, especially because of the lactates being high. You can go into metabolic acidosis, and then your BP starts dropping down, and because of your blood pressure trending down, obviously there is there's less end organ perfusion, and your end organ is not perfusing. Obviously, you'll have oliguria where your urine output is decreasing, or probably you can go anuric, and your creatinine gets built up. That is like a toxic to your kidneys. So all these kind of, when the toxicity increases, then you go into state called cardiac arrest. So you need to be, all these can be prevented by physical examination, by your non-invasive monitoring, and also with your invasive monitoring by doing your blood gases. So blood test kind of helps you find out the full blood count, electrolytes, cardiac enzymes, like troponins or creatine kinase, which are kind of early markers if your heart is going into ischemia. And then also cardiac chest X-ray. This is a normal chest X-ray, and you can see a cardiomegaly, a pulmonary edema happening over here. So cardiomegaly is where your heart is really big. See, so when you do an X-ray, this is a non-invasive monitoring as well. So when you do an X-ray, you kind of find out that your heart is big. There was this kid who came to us where the GP or general practitioner or his local doctor didn't do an X-ray, and was kind of in a state where this kid had fallen off from the cot or something, had suffered a head injury, and then came to the emergency. And when they did an X-ray, the kid had cardiomegaly, which was not diagnosed on an early stage. Things would have been prevented by then, but I think it was quite late at that point. But the kid came in with a head injury, but then came to ICU for this. And then you have pulmonary edema, where you can see this kind of an edema over here. This is usually in pulmonary edema that there's a swelling, or you can say edematous of pulmonary arteries. In our ICU, there's another system where we do non-invasive monitoring as well of cardiac output or perfusion, which is called near infrared spectroscopy. Hopefully I'm not increasing with the time. I think I am. But this is something I wanted to touch base on, is you just put some these kind of probes on the head or on the plank region, where it tells you the perfusion to your kidneys or your end organs, and also this tells you about the cerebral perfusion, and it gives you a trend. It just works on a laser light. So the laser light is emitted and it perfuses into your cell, like it goes into your cell, and it kind of gives you a trend based on the perfusion. So these are the numbers, kind of, you can see the trend. Sometimes when they trend downwards, it means that they're perfusing poor. Usually these numbers will be around 70s, but we don't have a definite number. We just take it as a trend. So if they're lowering down, it means they're not perfusing well. And it's usually used in cardiac surgeries or emergency situations. So you have the somatic saturation, and you have a cerebral saturation and a somatic saturation. Always remember the patient comes first, and then your equipment is only a mere adjunct. So it is just to tell you the numbers, but you need to look clinically how your patient is doing. Examination is a must, and which does not replace the clinician's clinical decision making. That's about it. And I'm sure you're having questions which look like this. Maybe your head is blown off with all my talking. So it's open to questions now. Thank you very much.
Swati, a very good afternoon.
Yes. Thank you. I'm so sorry. I think I took a lot of time.
No, but that was very interesting. And I should say that as a cardiovascular nurse, maybe I heard about all these things when I studied my master's. But things were not that very clear when I was doing my master's. But I think today you have done such a wonderful presentation with
thank you.
The details being dealt to so wonderfully. And I'm sure that you're a great teacher and
thank you.
A great clinician as well, because that could be reflected in the way you dealt with the topic by discussing the clinical aspects of what need to be looked into and how we need to focus on the patient first. So thank you so much.
Yes.
It was really wonderful.
Thank you, ma'am.
And
Thank you, ma'am.
in fact, I think I have understood very well, more than what I had learned during my master's. Thank you so much.
Thank you, ma'am. Thank you so much.
Thank you, Swati.
Thank you so much, Suchitra, ma'am.
There is no question in the forum.
I have one query which always was striking my mind, like as to how the jugular vein is being detected in these patients. Like you said that these insertions happen into the internal jugular vein. So how do they detect the jugular vein? Is it a approach or is it through ultrasonography?
It's mostly like, because our technology has increased so well, we usually use the ultrasonography. So we have a peripheral Doppler. So we use a peripheral Doppler, and then we usually run it across obviously on the jugular side. And then when you look into the Doppler, there is two ways that you can identify a vein and an artery. An artery is collapsible and a vein isn't. So when they try to press on the, like through the sonography, the probe, when you press on it, you can see the jugular veins. Sorry, the jugular veins are collapsible, the artery isn't. So when you press on the veins, they're kind of collapsible, and then you kind of insert it through the Doppler. Obviously, you can see it on the Doppler, and then you insert the catheter through the vein.
But is the blind approach also used? No.
Yeah. Like when I was working in Mangalore, yes, they used to use the blind approach as well, because usually the veins are peripheral, right? So you can see the veins up here, and when you actually palpate, you will feel the artery. So you go away from the artery, and then you just approach the vein. Especially with femoral, it's very difficult because the artery and the vein are quite very close to each other. But with the jugular, it's quite easy to mark because it is in the groove. So you go into the groove and then perform the Seldinger technique, they say. So you approach it through like a 30-degree angle or 40-degree angle, and you pierce through it. But they do use a blind approach. Sometimes what happens is you can't use a probe if the patient is like having burns or scalds on this patient. So you kind of go with and obviously when you puncture the artery or the vein, you understand through the blood, which is artery and which is venous. So venous blood is always darker in color, and artery is mostly bright color. So yeah.
so much. Thank you.
Thank you.
Thank you, Swati, for
Thank you.
a short notice for this presentation. Your presentation was wonderful and it is very informative. You have touched all the aspects starting from cardiac output till after and almost all the aspects like hemodynamic monitoring. Images, videos, it was very informative and it was well understood. Thank you once again.
Thank you, Suchitra.
And my
ma'am.
deep sense of appreciation for Dr. Fatima De Silva, Principal College of Nursing, and ex officio President, Alumni Association, NUINS, for encouraging and supporting throughout this series of webinar. Thank you, ma'am. And I also thank all the organizers for helping us, and my special thanks to all the delegates. Thank you, one and all.
Thank you very much. I just wanted to say one more thing. It's a really nice
Yeah.
approach by you all. Like when we were studying, we didn't have this kind of a thing where external people come and teach, which is really very good. And I think you all should keep going with this, especially in this time, or even if it's not COVID time. I think otherwise also it's very informative. Like I think I would have benefited a lot as well. But now that I'm complaining, I love my now getting out of Nitte. I realize it's very. It was the best college I have studied in. I feel. Thank you so much. Thank you.
Thank you, Swati. Thank you.
Thank you, sir. Thank you.